started the timer and here is your question. Right. If you have read and understood, kindly tell me, considering it critical care scenario, how would you manage this patient?
Since the first, I'll first go into the room and show my thing to the examiner. And since this is an RTA, I would follow the ATLS guidelines for management. The first thing I would do is first is airway, checking the airway and assuring that the cervical spine is stable. And for the airway, I would do look, listen, and feel. And we'll check for any foreign body in the mouth, and we'll first assess. We'll first clear that out if there is anything. And then after that, we'll check if there's any gurgling sounds or any stridor. We put him on a 15-liter mask, 15-liter non-rebreather mask, which is filled with the valve. And we'll also do inline mobilization of the cervical spine with the sandbags on the side and tape on the head. So that would be airway. And then after
how would
that,
you?
I would move.
Yeah. Yes.
Sorry. Go on, ma'am.
Yes. How would you take care of the nutrition for this patient?
Since the fact that he's already vomited twice and he's also had a GCS of 8, I think his airway will not be, is unlikely to be patent. So we'll first secure the airway, and then after that, we would possibly think about inserting an NG tube for his nutrition, and also start him on IV fluids whilst we wait for the diagnosis and for further management.
Even before NG tube, maybe wide bore cannula. Okay, yes, how would you manage, or how would you make sure there is secured ventilation maintained for the patient?
First, we will connect him to the saturation probe, and we'll connect him to all the monitors. And we'll, after assessing his airway, if he has any gurgling sounds or stridor, we'll make sure we first put in an oropharyngeal airway, do some suctioning, and then after that, ask intensivist and anesthetist for help in terms of intubation and for mechanical ventilation.
This patient, when it was arrived, had GCS of 15, and after 15 minutes, it was noticed to be 8. What do you think has happened to the patient?
Given that he's had a lucid interval where he's been GCS 15 and he's now dropped GCS.
Can you define lucid interval? What is
lucid interval? Is the interval between 2 amnesic episodes where the patient is conscious and is GCS 15.
Okay. Can you please tell me what might be the pathophysiology behind it if the patient has increased intracranial pressure?
Likely diagnosis for this patient would be an extradural hematoma. So thinking of the Monro-Kelly pathway,
yes,
it says that there are 3 components in the brain, which is blood, brain, and CSF. So if one component increases, it means that the other 2 will decrease. There'll be a compensatory decrease in the other 2 components. So in his case, there'll be an extra amount of blood which is pushing on his brain and also reducing his CSF flow. So that will lead to an increase in intracranial pressure.
Okay, can you please define the term Cushing triad?
Cushing's triad is it's marked by hypertension, bradycardia, and abnormal respiratory movements.
Yes. How would you differentiate it from Cushing reflex?
I'm sorry, I'm going to skip that one.
Okay, can you please tell me what's the normal value of intracranial pressure?
Ma'am, it's ideally between between 10 to 12.
What?
Millimeters of mercury.
Yeah, that's what I have to hear. Okay,
Sure.
can you name few ways in which you can measure intracranial pressure?
The first one is by insertion of an ICP bolt, an intracranial pressure
Define,
bolt.
classify them like invasive and non-invasive, and then tell me, please.
Okay. In non-invasive is by using an ICP monitoring, but like externally, and invasive would be monitoring with an ICP bolt, or you can also measure the cerebral perfusion pressure with an invasive line, invasive central line.
Subdural catheter, well, etc. Okay, yeah. Can you name few dangers which can be associated if you do a lumbar puncture in a patient who has already increased intracranial pressure?
We can expect herniation and coning of the patient if we do it with intracranial pressure.
Okay, what investigations would you do or would you ask for this patient immediately?
The first investigation would be a CT head.
Okay.
Along with, since he's also had an RTA, I think we should do a full screening.
If you do the CT scan, can you help me to read this, please? Can you please help me to read this?
Yes, ma'am. It's a right-sided extradural hematoma on the frontal parietal region, which is causing a midline shift and effacement of the lateral ventricle.
Okay, when patient has increased intracranial pressure, what type of medications or what medications you should use with caution?
Sorry, ma'am, I'm going to skip that.
Okay, when would you suggest surgery for this patient?
We would suggest surgery when, since he's already dropped his GCS, I think it's an indication for surgery. And even if, or his pupillary reaction is absent, and if he's got any lateral Gale's palsy, and head and nausea and papillary edema as well.
Okay, can you please tell me the components of Glasgow Coma scale?
Yes, ma'am. So it's verbal, and motor score.
Yes, if it's 8, then what is missing or what is present? What makes 8?
Ma'am, the I score is maximum of 4, verbal score is maximum of 5, and motor score is maximum of 6. I don't know the breakdown for the GCS because it's not given.
Okay. Yeah. All right. Can you name few indications when the patient should be intubated?
The first indication is when he's losing his airway. That would be the first indication. The second one is if he's had Cushing's reflex, and that's I can't think of anything else. I'm sorry.
Yeah, 2, 3 more. Okay, you'll revise. All right. Okay. Can you please tell me what are the indications? When would you consider doing the CT scan as your first choice or earlier?
When the GCS is less.
What is the criteria behind it? Yes.
It's a Canadian criteria. It's if there's a GCS of less than 15 for 2 hours post.
According to NICE guidelines, you can tell me.
According to NICE, yes, ma'am. And suspected open or depressed skull fractures and any sign of basal skull fractures such as hemotympanum, raccoon's eyes, and CSF rhinorrhea otoria, has greater than 2 episodes of vomiting, and age greater than 65, or the patient has been on any anticoagulation. A medium risk is when there's a retrograde amnesia of more than 30 minutes and the dangerous mechanism of injury, such as fall from 3 feet.
Can you please suggest some diuretics that can be used in this patient, considering increased intracranial pressure?
We can use mannitol. Mannitol is the second choice of diuretic, and you can also use furosemide. Sorry.
Why would you suggest mannitol? Yes,
osmotic diuretic.
Very good. What is the dose that you'll
as an osmotic diuretic?
Yes, please.
0.5 to 1 gram per kg per kilogram.
Over how long? Over
we can give it over.
Can you give
15 to 15 minutes, but we can give it over 15 minutes. As far as I'm aware.
Okay, what is the mechanism behind it? Why cannot you give it rapidly?
Since it's an osmotic diuretic, it causes displacement of the intravascular volume to the extravascular volume, which can result in edema as well.
Good.
So it can't be given rapidly.
Cannot be. Yes, very good. Okay, good. Started the timer, and here is your question. 1 minute will be given to read the question. Right, if you have read and understood, kindly identify these marked structures. Can you please identify these structures from 1 to 8, please?
I can't see the numbers quickly, but yeah, I think I'll follow your cursor.
Okay. This one, if you can identify number 1.
Superior sagittal sinus.
2? 2 is this one, right?
Is it the straight sinus? I can't
Okay,
see.
3. 3. This one arrow comes here.
It's a great cerebral vein.
4.
4. Is it
Quickly.
the sigmoid?
5. This is 5.
Inferior petrosal sinus.
6.
Superior petrosal sinus.
7.
Sphenoprite. Is it going forward? Cavernous sinus.
It's here, 7.
Basilarity venous plexus. I don't know where it is.
Okay,
going,
we'll
but
do
if
it.
it's
8.
8 is the sphenoparietal.
Can you name all the venous sinuses and how they run? Can you please tell me?
So the superior sagittal sinus runs in the superior border of the falx cerebri. The inferior.
Classify them into paired and unpaired, please, and then
Awesome.
tell me how many of them are what.
Okay. So the paired ones are transverse sinus, sigmoid sinus, superior petrosal sinus, inferior petrosal sinus, cavernous sinuses, and then sphenoparietal sinus. And
where would you find superior sagittal sinus?
It's in the superior border of the falx cerebri.
Yes. And it runs from where to where, please?
It runs from
superior cerebral vein,
okay.
diploid veins, emissary veins. Okay.
Are
Can
these
you
not the tributaries which drain into that?
Yes. So it forms. Yes.
Okay.
That's what I meant. It runs or it is formed by.
Okay. All
Okay.
right. Yeah.
Can you please tell me what is cavernous sinus?
So cavernous sinus are the paired dural venous sinuses which lie on both sides of the sella turcica. They are located in it forms one of the components of the cavernous sinus.
And they drain blood from where?
They drain blood from the superior
ophthalmic vein and
facial veins
yes.
Through the superior ophthalmic vein and emissary veins of the pterygoid plexus.
Yes, and sphenoparietal sinuses.
Sphenoparietal sinuses, and they drain into the basilar plexus and the anterior and posterior intercavernous sinuses.
Okay, there is maybe more as well. What do you understand by cavernous sinus thrombosis?
So cavernous sinus thrombosis is basically the infection or thrombosis caused when the thrombus or infection spreads from the danger area of the face.
Yes.
It's been drained by the facial vein, and these are valvulus veins which drain the blood through the superior ophthalmic vein, which drain into the cavernous sinus and so carry the thrombus or the infection along with it.
Can you tell me the signs of thrombosis? How would you know the patient is suffering from cavernous sinus thrombosis?
Painful eye.
Yes, and
blood
painful and swelling. Okay, and what else? Pulses of which cranial nerves?
Third, fourth, branches of fifth and sixth cranial nerves.
Yes, good. Okay. Anything else? Gradual loss of vision.
Yeah, this is, I said, and blooding and loss of vision.
Okay, can you tell me how cerebrospinal fluid is formed?
Oh, I didn't.
Oh, okay.
Can you say this question? I didn't read this one.
Okay, we'll cover it again. All right. Can you tell me what passes through the hypoglossal canal?
Through the hypoglossal nerve.
And one artery, ascending pharyngeal artery. Okay, why transverse sinus is called transverse sinus?
Because it has a transverse course which runs
in the groove
onto the groove on the inner surface of the occipital
bone. Yes.
Bone.
And it drains from where to where? Please tell me the course.
So it will drain from the confluence of the sinuses.
Yes,
to the sigmoid sinus.
Very good.
To the sigmoid.
Okay. Why sigmoid sinus is called sigmoid sinus?
Because of its shape, I guess.
Sigma. Yes, very good. Very good. Yes.
Yes.
Okay.
And it drains the and it becomes the internal jugular vein.
Very good. Okay. Can you please tell me what can make irreversible damage to the vestibulocochlear nerve?
Irreversible damage.
Yes.
To the vestibulocochlear nerve. I think I read it, but I'm not. I'm sorry.
Okay. All right. Do you know what acoustic neuroma is?
It's basically the tumor of the schwannoma or tumor of the vestibulocochlear nerve, in which
would you be able to tell me why patients with acoustic neuroma would hear loud sounds on the affected side?
Because the facial nerve is runs closely with the vestibulocochlear nerve, which supplies the stapedius muscle, and the stapedius muscle basically controls the stapes, one of the bones of the ear ossicles. Because of the paralysis of that muscle, the stapes is oscillations are not controlled. And because of that, there is increased I can't remember the word, which
okay. You
causes
can pause if
this
you want. Can you tell me what you understand by the term clivus? C-L-I-V-U-S.
It's the part of the bone which is present at the interior, which is present interior to the foramen magnum, and is in between the diaphragma celli and the foramen magnum.
Yes.
And it
in examination, they will ask you to identify it. Okay, that is gone. But I'm telling you, even if they show you a picture of a section or a model, they will ask you to identify it.
Where the basilar plexus
at the
is.
skull base, yes. There will be a shadow depression. behind
Yeah,
the
where the basilar venous plexus is present, isn't
Yeah.
it that way?
Yes.
Clevis?
But they
Okay.
will ask you to identify it. Okay,
Okay,
that's
yeah,
why
that's
it's
fine.
important.
Okay.
Right. Ben has gone. I was asking you very slowly, and then yes, I think I have asked you. I was thinking, because when they ask you dural venous sinuses, then they do ask you for the CSF
Okay.
here.
I'll do
So
again.
yes, we'll do again. Yes, definitely. Yeah, next time we'll do the, yeah. All right. Okay, now I'll show you one thing.
Mhm.
All right. All right. Okay. Now we'll verify what you were identifying. So what did you say? Number one is?
Superior sagittal sinus.
Yes, superior sagittal sinus. Number two?
I thought it is, oh, it is around it. So it's the straight sinus.
It's a straight sinus.
I'm not looking at the picture. Yeah.
You should look now, because now we're solving the, yeah.
Okay.
So now you can look, or I'll ask you and then we'll confirm. Okay.
Okay.
Number two, you can confirm now. This is straight sinus.
Sinus, yeah.
Okay. Number three is here.
Great.
Great
Cerebral.
cerebral vein. Yes. Is it what you said?
Yes, I did.
Yes, good. Okay, number four is here. Okay, look at the
Sigmoid.
cursor now.
Yeah, sigmoid. Sigmoid sinus.
Yes. See the shape, sigma shape?
Yes.
Sigmoid.
Yes.
Okay, number five, please. It was
Inferior
this.
petrosal sinus.
Yes, this is correct, right? So this
Yes.
is inferior, and this is superior.
Period. Yes.
Six is superior. This is right.
Yep.
Now seven.
7 is cavernous sinus.
Very good. Yes.
Oh, yeah.
Here it's cavernous.
Mm-hmm.
Why?
Mm-hmm.
Look at the shape. How is it?
Yes.
Then you can tell. You
It's
can
well-
remember it. Like you can have your own keys in your brain. You
Yes.
can have your own. Yes. So okay, 8.
The phenoparietal.
Very good. Yes. Very good. That's it. So this
Somebody
is
has
the solution.
appreciated me.
Sorry.
I was feeling like I was in an exam. Somebody appreciated me, but I felt like I was in the exam. I
That's
got
the
that
feeling you have to
palpitations.
give. That's why I call it mock exam.
It's the benefit of this session. Yeah, I was
Yeah.
about to say.
Good. Very
Like I
good.
got-
Timer, and here is your question.
Okay.
Right. If you have read and understood, considering it history taking station, begin your history, please.
Okay. Hello.
Hello. Hey.
I am Mohammed Alayan, one of the exam candidate. Might I confirm your name and age, please?
I'm James. I'm 28 years old.
28.
Nice to meet you, Mr. James. Today I have been asked to ask you a few questions regarding your condition. Are you okay?
Yeah, that's fine.
Okay. How can I help you today?
I've just been having worsening pain in my left knee for the past 3 months.
I am sorry to hear that. The pain move anywhere?
No, it's just in my knee.
Mm-hmm. When did you first notice that the pain?
It was about 3 months ago. I had a fall when I was playing football, So ever since then, it's just been gradually getting worse.
Gradually?
Yeah, it's been gradually getting worse.
Start suddenly or gradually?
No, it started suddenly, but then it's been progressively getting worse.
I am sorry to hear that. Did it come and go?
No, it's still there.
Any specific time during the day that the pain increase?
No, when I rest in the morning, it's fine. But then when I start walking or doing something throughout the day, the pain sort of increases.
Anything that the pain increase or the stop?
No, it improves with painkillers, but then it gets worse when I'm walking.
Could you please describe the pain for me? Colicky or cramping or stabbing?
It's a dull aching pain. And it's sometimes colicky when not colicky, it's sometimes stabbing when I'm walking.
How the paddling is affecting your day-to-day life?
It's badly affected because I can't play anymore, and I have pain when I'm walking, and I sort of slip as well a lot of times.
If you have rate the pain from 1, how would you rate?
I think I would rate it about 6.
I am sorry to hear that. Do you experience giving away when walking?
Yeah, I do have difficulty walking.
Do you experience locking of your knee?
No, it doesn't lock.
Have you noted any stiffness in your joint when you walk up and the morning?
No.
Hello?
She said no.
Hi,
Yes.
sorry, I said no. Sorry.
Have you noted any swelling of your knee or redness or any discharge?
There's a bit of swelling, but there's no redness or discharge from there.
I am sorry to hear that. Have you noted any weakness or numbness of the leg?
I'm sorry, have you noticed any weakness, did you say?
Numbness or weakness of the leg?
Redness.
No. I haven't noticed any redness.
Have you noted any rash anywhere in your body?
No, I haven't.
Have you noted any significant weight loss?
No.
The pain present all the day or increase at the night?
It increases at night.
I am sorry to hear that. Do you have any history of the trauma before?
Yeah, I fell down about 3 months ago. That's when all of this pain started.
I am sorry to hear that. Do you notice any change in the shape of your knee?
No, I haven't.
Do you have any other medical condition?
No, I'm not. I don't have anything else.
Do you have any surgery before?
I had one surgery in my knee about 4 years ago.
I am sorry to hear that. Do you take any medication?
I've just been taking the painkillers that's been prescribed, but other than that, nothing else.
Do you have any allergy against this non-steroidal or painkiller?
No, I don't.
I asked some personal question. What's your occupation?
I play football.
Who at the home with you?
My parents.
Do you smoke?
No.
Do you drink alcohol?
Occasionally.
Do you drink alcohol?
Yeah, occasionally. Once in a while.
How many units per week?
I don't know units, but I can tell you that I drink about 1 beer can a week.
Anyone in the family have the problem?
No.
Can you please summarize your case now?
Okay, Mr. John, 28 years old, football coming to surgical outdoor complaint of worsening pain in the left knee since 3 months. Have history of the trauma from the 3 month, and Mr. John operation on the left knee, and now Mr. John drinking alcohol. My professional diagnosis could be osteoarthritis. Another differential diagnosis could be rheumatoid arthritis, septic arthritis, and be referred from the spine or back pathology.
How do you plan to manage this patient?
Yeah, the plan of management to complete my examination and the investigation, like full blood count, ESR, and the CRP, and the C-reactive protein, and the rheumatoid factor, and the knee X-ray, standing, and weight bearing, AB, and lateral view.
What should be the treatment that you can offer this patient?
Yeah, the treatment could be conservative and surgical. Conservative advice to decrease the weight and regular exercise, and give the patient analgesia, heat application to the joint, and physiotherapy and intra-articular steroid. And surgical arthroscopy and arthrocentesis, osteotomy, and the total and partial knee replacement.
Okay, in how much time do you think this patient would be fit enough to play football?
Approximately from 9 months to 1 year.
Yes, good. Okay. Okay, Bell has gone, right. So what were the things that you have missed? Anyone want to give feedback to Dr. Mohammed? Good, Dr. Singh. Yeah. Yes, please.
No worries. I was just going to say, Dr. Elian, did you have difficulty understanding what I was saying?
Could be because his network is not good.
Yeah, maybe I understand maybe the internet weak, disconnected.
Your connection was weak. Okay. I just wanted to just say one more thing. I understand that you're sympathizing with the patient, and you've done that really well because you've said it exactly like when he's got pain and everything. But then I think, like, if you say it very frequently, it will sound very like sort of like rehearsed. So just make sure you say it, sort of spaced out, if that makes sense. Ma'am, I don't know if
I understood what you mean. Yeah, but then once you're doing face to face, it's kind of different to when you're limited with the network. If you understand what I mean, maybe that's the issue he was facing. He couldn't hear us, and he was like kind of repeating himself. So yeah,
I think it was just a network problem.
Yes, Dr. Mohammed, what were the things in your history taking that you missed because of the time? Bell went. You were asking who lives with you, and then alcohol history, and then idea, concern, and expectation you couldn't ask. Other family history family history you couldn't ask as well. Occupational history you did ask, okay, and then past surgical history you did ask. So yeah, family history, and then ice. Anything else? So like when the bell goes and
ice.
Yes. So Dr. Mohammed, when bell goes and I say you present your case, then you begin with what you have missed first. Then you say, okay, if time would have allowed, I would have completed my history. And then you sum up your case. And then when you were summing up your case, you did mention that patient drinks alcohol, but then patient drinks only occasional alcohol. Even yes, when you're mentioning it, then you can, if you want to mention, you can mention it last, because it's not a big deal that patient drinks. not too much, right?
Okay, ma'am.
Yeah, that's it. Yeah, rest you knew everything and you answered very quickly. I actually had few seconds when bell went, so very good. Thank you.